Hi everybody, welcome to part 3 of Dr. Manny's YouTube Learnshop's Arterial Blood Gases. The learning objectives for this session are to review compensation in arterial blood gas analysis and review the Henderson-Hasselbalch equation in a simplified, modified way, and then look at compensation, which can be full or partial, which from my perspective is often misunderstood. So, what then is compensation in arterial blood gas analysis? Compensation in this situation means helping to maintain homeostasis and therefore maintaining a normal blood pH, which you now comprehend as being extremely narrow, 7.35 to 7.45. The lungs or the respiratory system help the kidneys, which is the metabolic system, to maintain homeostasis, and vice versa. They both help each other. The lungs help the rest of the body, and the rest of the body, or essentially the kidneys, help the lungs. That's compensation. Here's an example of respiratory compensation and what it means. In the situation, for example, of heart failure, or it could be diabetic ketoacidosis, it could be elements related to renal failure, liver failure, etc. failure. Aerobic metabolism requires oxygen. This is normal. It's our major way of providing metabolism for the body. We use oxygen. But then the heart fails, or it's failing. And this lowers cardiac output. Remember, cardiac output provides the body with oxygen for tissue metabolism. As a result of low cardiac output, this decreases oxygen to the tissues for tissue metabolism. So therefore the body comes in to try and support the failing system, the heart, oxygen, with anaerobic metabolism, which utilizes no oxygen, and it increases. But as a consequence of that, anaerobic metabolism produces much more lactic acid. The lactic acid accumulates, and as a consequence, this could decrease the pH, the arterial pH, to less than 7.35. However, as the pH becomes more acidemic, this activates the brainstem, the respiratory center in the medulla oblongata, to increase the rate of breathing, tachypnea, and hyperventilation, to try and excrete CO2, more CO2. This is the lungs helping or compensating for the increase in lactic acid production. Lactic acid is a non-volatile acid. It can't be blown off. CO2 can be blown off. It can be excreted. So this increases CO2 removal and returns the pH, God willing, to normal. 7.35 to 7.45. Here's an example of metabolic compensation. The disease process that we're going to look at is a chronic obstructive lung disease, such as emphysema. And in emphysema, even though sometimes the person involved is breathing quickly, called tachypnea, they're still hyperventilating. And because of their disease process, they can't excrete CO2 effectively. So therefore, as a consequence of chronic lung disease and hyperventilation and CO2 retention, this increases the acid load in the body and may decrease the pH to less than 7.35, indicating acidemia. However, the kidneys try and help, but they're pretty slow. And they start activating after about probably 12 hours and use their maximum capacity at probably around about 72 hours. And the kidneys slowly increase bicarbonate retention and hydrogen ion excretion. This increases the bicarbonate or base load in the blood, but decreases the hydrogen ion and acid load in the blood. This is the kidneys helping the lungs to excrete CO2, acid removal, as you'll see when we look at the Henderson-Hasselbalch equation. This increases the bicarbonate to greater than 28 millimoles per litre and the base excess to greater than +3. And the main rationale is to attempt to return the pH to normal levels to prevent intracellular and cellular damage. This is a modified version of the Henderson-Hasselbalch equation. It's simplified. As you can see, the lungs excrete CO2. The kidneys excrete hydrogen ions and bicarbonate ions. So, in the centre you've got the blood transporting carbonic acid. Carbonic acid is H2CO3, which is formed by CO2 and water, or it's formed by hydrogen ions and bicarbonate. So this equation is basically demonstrating that it's very volatile. It can move in any direction very quickly. So here, for example, if you get CO2 and water combining, it forms carbonic acid in the blood. The blood then can be transported to the kidneys, where it dissociates into hydrogen ions and bicarbonate and can be excreted by the kidneys if the kidneys are working effectively, or vice versa. Hydrogen ion and bicarbonate in the kidneys can be converted to carbonic acid, which is transported in the blood, which can move to the lungs, and the lungs can excrete carbon dioxide and water. So normally, acid, carbon dioxide, is excreted by the lungs. Acids, like hydrogen ion, urea and creatinine, and uric acid, is excreted by the kidneys. But put it into your mind now, carbon dioxide, carbonic acid are potentially volatile acids. They can be excreted by the lungs. Volatile means they can be excreted by the lungs. Non-volatile cannot be excreted by the lungs. And non-volatile acids are in the form of urea, creatinine, and uric acid waste products. They can only be excreted by the kidneys. So hydrogen ion and bicarbonate are converted into carbonic acid. CO2, carbon dioxide, and water are converted into carbonic acid as well. Carbonic acid is volatile and can be transported to the blood, to both the kidneys and the lungs. And this allows hydrogen ions to be excreted. Here's an example of the Henderson-Hasselbalch equation. You've got increasing urea, creatinine, uric acid, which cannot be excreted by the lungs, only by the kidneys. This contributes to a high acid load and increasing hydrogen ions. The hydrogen ions, however, can be excreted by the lungs in the form of CO2 after it's converted to carbonic acid. So the high acid load, hydrogen ions, as you can see, and bicarbonate is converted to carbonic acid. The blood transports it to the lungs, where it dissociates into CO2 and water, and it can be excreted. The lungs breathe out or hyperventilate to try and excrete more CO2, but remember, the lungs cannot excrete urea, creatinine, or uric acid. And as a consequence of that, renal failure, the metabolic acidosis increases. because we continue to make waste products such as urea, creatinine and uric acid, and therefore in this situation the lungs fail to help compensate. Here's an example of respiratory failure as a consequence of, let's say, chronic lung disease. In chronic lung disease, emphysema, chronic bronchiolitis, bronchiectasis, there's an increased CO2 load, carbon dioxide load. And as a consequence of that, the CO2 builds up, converts to water, causes carbonic acid to accumulate, and you increase the acid load. So carbonic acid increases. However, the CO2 and water as carbonic acid can be converted to hydrogen ions and bicarbonate ions, and the kidneys then excrete more hydrogen ions and retain more bicarbonate ions. And as a consequence of that, this decreases the respiratory acidosis. Compensation becomes successful. So points to remember, think of it now. Compensation is typically opposite the pH problem in most cases. So for example, pH of 7.3 indicates acidemia acidosis. The bicarbonate of less than 22, 18 millimoles per litre, indicates a metabolic acidosis. However, the PCO2 is 30, it's less than 35, which indicates an alkalosis. This is demonstrating that there is respiratory compensation. You've got a metabolic acidosis and you've got a respiratory alkalosis, which indicates compensation. Additional points to remember are that compensation can be full or it can be partial. And from my perspective, it's often misinterpreted. So let's review it. Partial compensation basically means if the pH is not within or close to the normal ranges. Despite persistence of the abnormality, this could be respiratory or it could be metabolic, then a partial compensation may exist. So what it's basically saying is partial compensation means that despite the respiratory or the metabolic problem, the pH may be returning to normal. It's not normal, but it's trying to get to be normal. If there's no change in the pH despite the respiratory and metabolic problem, then there's no compensation. Full compensation, however, means that if the pH is returned to normal, despite still having the respiratory or metabolic problem. If it does return to normal, then full compensation has occurred. If it hasn't returned to normal, partial compensation may have occurred. If the pH hasn't changed at all, no compensation has occurred. Compensation means that we are trying to get the pH back to normal, and this should be able to be demonstrated in the blood gas. Here's an example. Take an acute event. You've got a 45-year-old female who's got emphysema. She's got chronic lung disease. And unfortunately, she's developed a chest infection. And because she's developed a chest infection, she now goes into probably a respiratory problem. I'll let you look at it. The pH is 7.3, less than 7.35. This is an acidemia. However, as I said, we've got to look at to see what has caused the acidemia. The pH tells the story. Is it an acid problem or is it a base problem? Is there an acidemia or an alkalemia? In this situation, it's an acidemia. Then we move on to the PaCO2. She's retaining CO2, which means she must be hypoventilating. If you're not ventilating properly, you can't get rid of CO2. So you're hypoventilating. She's got PaCO2 PCO2 of 65. PCO2 should not exceed 45. In actual fact, it should remain at about 40 if you're ventilating properly. Bicarbonate and base are normal, and the PaO2 is indicating that she's hypoxemic. She's got hypoxia. It's less than 80. And she's probably breathing room air. For us, she's breathing room air. So, this is hypoxemia and a respiratory acidosis. That's the problem at the moment, reflected in the blood gases. Now, let's say an hour later, you've got some renal compensation, even though renal compensation isn't that quick. It takes anything from 24 to 72 hours to become effective. But this is just an example. So, in an example, an hour later, the bicarbonate is being retained by the kidneys. We can see it's gone from 24 or whatever it was to 27 millimoles per litre. And the base excess is now more than 0 plus 3. The pH hasn't changed though, so there's no compensation at the moment. The PCO2 and the oxygen remain the same as well. So therefore, the kidneys are retaining bicarbonate and total body bicarbonate reflected in the bicarbonate and the base excess. However, the pH hasn't changed. It's still 7.3, so therefore there is no compensation at present. So what you've got is no compensation because the pH is still unchanged, despite retention of bicarbonate and probable excretion of hydrogen ions. Then 4 hours later, there's more renal compensation. There's more bicarbonate being retained by the kidneys. We can see that. It's gone from 27 to 30 millimoles per litre. It's gone from plus 4 to plus 6. So the alkaline reserve bicarbonate has increased and the total body bicarbonate has also increased. And, have a look, the pH has changed. It's not normal, so therefore there's been partial compensation. The body is trying to get the pH back to about 7.35 if possible. Despite the problem persisting, PaCO2 65, PaO2 55. So what you've got is a partial metabolic kidney compensation because the pH is returning to normal. Now let's say 10 hours later. Hypoxemia and respiratory acidosis still persist. She's got a chest infection. She's going to need antibiotics, and the antibiotics aren't going to be effective straight away. However, the pH is now normal. Bicarbonate has increased even more, 30 to 33. Base excess plus 6 to 8. So therefore, what she's got is full metabolic or renal compensation. The pH, despite the hypoxemia and respiratory acidosis, which is persisting, is now normal within a normal range. So therefore, the cellular and the intracellular components of your body cells are going to be happier. They don't like changes within their pH range. They become damaged, ineffective, problematic. Now let's look at some of the common acid-base disturbances. The first one that we'll look at is respiratory acidosis. And as we've mentioned previously, in previous courses, the common causes are due to toxins which may affect the respiratory centre, causing hyperventilation. Things like respiratory depressants, opioids, benzodiazepines. Then you've got central nervous system diseases, like myasthenia gravis. You've got others that relate to airway flow obstruction, which could be asthma, chronic lung disease such as emphysema, bronchiolitis, sleep apnea problems, and airway edema, which could occur in asthma, and allergy status. Hypoventilation results in a pH of less than 7.35 and a PaCO2 of greater than 45 millimeters of mercury. This reflects respiratory acidosis. Respiratory alkalosis is to do with hyperventilation. Common causes are related to extreme stress and anxiety, sometimes psychological or mental disorders can promote this. Pulmonary disease, heat, thermal insults, high altitude sickness, salicylate poisoning such as aspirin, acetaminophen overdose, fever, cardiac diseases or failure, and sometimes even in acute care areas such as improper use of mechanical ventilation, hyperventilating them, or even in the previous one, respiratory acidosis, hypoventilating them. But in this situation, respiratory alkalosis, we're talking about hyperventilation. And hyperventilation will result in a pH that is greater than 7.45 and a PaCO2 of less than 35 millimeters of mercury. You're exhaling too much carbon dioxide. Then we've got metabolic acidosis. And common causes for this are gastrointestinal bicarbonate loss, which is more common in pediatrics than it is in adults. And they can lose a lot of bicarbonate in diarrhea, even in some forms of vomiting. You've got renal tubular acidosis, drug-induced hyperkalemia, early renal failure and administration of some acids. And this is primarily related to using or losing bicarbonate. And what we see here now will be a pH that is less than 7.35 and a bicarbonate that is less than 22 millimoles per litre, which reflects a base deficit of less than -3. Metabolic alkalosis is another acid-base derangement, and common causes include loss of stomach acid, vomiting, severe vomiting, which can occur in gastroenteritis, hyperemesis gravidarum during pregnancy. It could be the excess use of antacids and diuretics. It can be related to hypokalemia, heart, kidney, liver problems, or it can be hereditary, related to genetic issues. And this is where you gain base or lose hydrochloric acid, and the pH is greater than 7.45 and the bicarbonate is greater than 28 millimoles per litre, which reflects a base excess of greater than +3. So now let's review acid-base disturbances that are compensated, and it's often misunderstood. When we look at respiratory acidosis, for example, with metabolic compensation, remember, as I said, the pH is typically, not always, typically opposite to the compensation. So have a look here. Remember, respiratory acidosis relates to hypoventilation, retaining too much carbon dioxide. So if it's an acidosis, the pH will be less than 7.35. The CO2, the PaCO2 will be greater than 45. So pH and PaCO2 are the same. They reflect a respiratory acidosis. However, when we come to look at the bicarbonate and the base, we see that the bicarbonate is greater than 28, which says alkalosis. The base excess is greater than 3, which says alkalosis. They're opposite. They're opposite to what the story is telling you. So therefore, this will reflect as a respiratory acidosis with metabolic compensation. The kidneys are retaining bicarbonate and trying to get rid of acid, hydrogen ion. In respiratory alkalosis with metabolic compensation, Remember again, the pH is opposite to the compensation. The pH tells the story. Less than 7.45 is alkalosis. PaCO2 less than 35 is alkalosis. However, the bicarbonate is reflecting a bicarbonate less than 22, which is acidosis. A base deficit of less than -3, acidosis. So therefore what you've got here is respiratory alkalosis with metabolic compensation. Typically doesn't often occur, but if it does, that's what it would look like. Metabolic acidosis now with respiratory compensation. I know I'm being repetitive, but I'm going to say it again. Remember, pH is typically opposite to the compensation. So have a look here. The pH is telling the story. Is it acidemia or alkalemia? Well, the pH is less than 7.35. This is acidosis, or I prefer acidemia. Then you've got the PaCO2 is less than 35. This is reflecting alkalosis, so it doesn't fit the picture. So find what fits the picture. Oh, the bicarbonate is less than 22, acidosis. Base excess, or really deficit, is less than 3. So what you've got is an acidemia pH, bicarbonate acidosis, base excess acidosis. This is a metabolic acidosis. What is opposite to the pH picture is the alkalosis. So what you've got is a metabolic acidosis with respiratory compensation. The pH is typically opposite to the compensation. Then the final one is metabolic alkalosis with respiratory compensation. Yes, remember, the pH is opposite to the compensation typically, which means not normally, but usually. So when we look at it, the pH tells the story. It's greater than 7.45, there's an alkalosis. But when we look at the PaCO2, it's not saying alkalosis, it's greater than 45, this is acidosis. So ignore it for the moment. Go to the bicarbonate, greater than 28, alkalosis, fits the pH picture. Base excess, more than +3, alkalosis, fits the pH picture. So what you've got is acidemia, so alkalemia in the pH, alkalosis, bicarbonate, alkalosis, base excess. So what you've got is a metabolic alkalosis. The PaCO2 is opposite, acidosis. So therefore, this indicates that you've got a metabolic alkalosis with respiratory compensation. The pH is typically opposite to the compensation. Okay, let's review. What's your interpretation of this blood gas? Now, the PaO2 is 110, but we know that that can be high because they're hyperoxic, breathing 40% face mask oxygen. Acid base is really just pH, PaCO2, bicarbonate and base. PaO2 is just looking at oxygenation, whether they're hypoxic, hyperoxic or euoxic. So when we look at the pH is telling us they are now in an alkalemia. It's greater than 7.45. The PaCO2 is 32. They're hyperventilating. They're getting rid of too much carbon dioxide, which fits the pH picture. Alkalemia, alkalosis, respiratory. Otherwise, bicarbonate base are normal, so this is a respiratory alkalosis. They're hyperventilating for whatever the reason. You'll know that anyway because of their history and their physical assessment. Then you've got the second blood gas. pH 7.57. This is alkalemia again. PaCO2 28. They're hyperventilating. It's less than 35. Bicarbonate and base are normal. PaO2, however, is low. They're hypoxic. And we'll just assume that they're on room air. So the interpretation is respiratory alkalosis with hypoxia. Revision 3. This is you now. You do this. You think about it. What's your interpretation? We can say straight away their PaO2 is low, they're hypoxic. It's less than 80. 80 to 100 is the normal range on room air. So they're hypoxic. What about the acid base? pH 6.75. What are they? Acidemic or alkalemic? They're acidemic. They're in acidemia. It's less than 7.35. Why are they acidemic? Let's look at the PaCO2. It's greater than 45. They must be hypoventilating. If they're hypoventilating, they're retaining carbon dioxide. That's why they've got a PaCO2 of 85 millimeters of mercury. The bicarbonate is low as well, indicating acidosis. It's being used up for some reason. The base, total body bicarbonate, is being used up. It's minus 10. It shouldn't be more than minus 3. So therefore, what do you think we have apart from hypoxia? The CO2 fits the pH, respiratory acidosis. But the bicarbonate and base do as well, metabolic acidosis. So what you've got is hypoxia and a combined respiratory and metabolic acidosis, which could be a person with diabetic ketoacidosis. They've become compromised because of the acid load in their central nervous system, and they've become unconscious, and they're hypoventilating as well. Combined respiratory and metabolic acidosis. But we don't know the patient's history or physical assessment, but we would in a real life situation. Revision 4. Your turn again. They're breathing room air, which is great because their PaO2 is normal, between 80 and 100. We look at the pH, and the pH is reflecting alkalemia, 7.62. Now we've got to find something that fits the alkalemia. The PaCO2, it's normal, it's 42. Between 35 and 45 is normal. The bicarbonate and base, however, are abnormal. They're abnormally high. Greater than 28, we've got 35 millimoles per litre. The base is more than plus 3, plus 9. So therefore it fits the picture that we have an alkalemia, but it's from the metabolic component. This is a metabolic alkalosis. Then we've got revision 5. They're breathing room air, let's say, 21% oxygen. So therefore they're hypoxic because it's less than 80. So already we know they're hypoxic, or they have hypoxemia. Let's go to the pH. pH is normal, 7.36. PCO2 is abnormal, it's 65, indicating hypoventilation, retaining CO2. Bicarbonate is high, base excess is high. So this is the difficulty. Unless you know the history or the physical assessment, it's difficult to interpret what the problem could be. However, what you've got then is hypoxia with a fully compensated respiratory acidosis, or you could have hypoxia with a fully compensated metabolic alkalosis. But let's just pretend this patient's got respiratory problems, chronic lung disease, chronic obstructive pulmonary disease, and as a consequence of that, you've got full decompensation. The kidneys have retained bicarbonate, to compensate for the increased CO2 load, which isn't going away. This is a chronic problem. However, the acid base in the pH is normal. So this is a fully compensated respiratory acidosis. But unless we know the patient's history, we could also say that this is a fully compensated metabolic alkalosis, because the lungs are hyperventilating to retain CO2. This typically doesn't happen in real life because, again, your respiratory centre won't allow it. So let's stick with what we've got, a fully compensated respiratory acidosis. This is the last one for you to do. You do it. This is now a blood gas that you've been given. pH is 7.32. What do you think it is? Acidemia or alkalemia? It's less than 7.35. This is an acidemia. Does the CO2 fit with acidemia? Well, it's 28. So it doesn't fit the picture. It's less than 35, which means they're hyperventilating. This is an alkalosis. Ignore it for the moment. Bicarbonate is low, base is low. It's a base deficit. You're using up bicarbonate for some reason. This is now a metabolic acidosis. So it fits the pH picture. The pH picture, acidemia, metabolic acidosis, base acidosis. So this is a metabolic acidosis. And remember, we said the compensation is typically opposite. So you've got the lungs hyperventilating alkalosis. So this is going to be a metabolic acidosis with respiratory compensation. Okay, that concludes part 3 to the ABG Learnshop. Now, if you found these of any value, review some of the other ones. Some of the other Dr. Manny Learnshops. Thanks, and hopefully I'll see you again.